Hi, this is Dr Shraddha at Helios. I'm a dermatologist, and in continuation with our initiative on bringing awareness on PCOS, today we have Dr Priya Kannan, who's a senior consultant fertility specialist at Garbharakshambike Fertility Center. And hi, Dr Priya.
Hi.
So we're trying to bring awareness on polycystic ovary syndrome because patients do get apprehensive when we use the term PCOS to them, that too for the first time. So basically, what is PCOS or what is polycystic ovary syndrome?
PCOS, as you rightly said, it's polycystic ovarian syndrome. It is majorly, it's a syndrome of combined of few features. One is anovulation, that is irregular menses. Hyperandrogenism, that is certain characteristics of hyperandrogenism such as acne, that is pimples, a lot of pimples, excessive hair growth, oily skin, having some other skin problems, and hoarse voice. All these things. There are other more features also. I'm just listing few which is very commonly seen in PCOS. And third is irregular cycles. So one is our irregular cycles, hyperandrogenism, and the third one as such is another thing we can see only on scan, which is a polycystic ovary. I mean, it started as a polycystic ovary, but then these two were actually found out. So when we see the scan, there will be a typical morphology of the ovary, which is called the polycystic ovary. That is, the volume of the ovary will be large with a lot of small follicles in it. And there is a typical criteria to diagnose PCOS, which we follow as fertility is the Rotterdam criteria, in which they have three. One is the menstrual irregularities, hyperandrogenism, and this polycystic morphology of the ovary. Either of the two of these three must be there for us to diagnose a patient as polycystic ovarian syndrome. There is polycystic ovary we generally call, but it is actually a syndrome which encompassing the whole thing.
So basically, if it's only, a lot of people come with the scan report of polycystic ovaries and then they think they have PCOS. So you explained it clearly that it's not just the scan report, it needs to have other features as well. So you said hyperandrogenism. Like, what do you mean by hyperandrogenism? Just generally, lay people will not understand what is hyperandrogenism.
Yes, so hyperandrogenism is a very inherent factor or a phenotype, that is, it is expression. How PCOS comes around is generally girls will start with as having irregular cycles. The next one they will complain of is having excessive hair growth in areas such as the face, the moustache area, the chin area, hair, and arms and legs and all that area. And another thing that can have is a frontal baldness. That is a male type of baldness can also happen. So excessive hair loss. So these are the things that come around us, which we see as hyperandrogenism. But then what actually happens inside is the hormone is that there is an excessive of male hormones in the body, such as the DHEA and other androgens, which is why we have such phenotype or the features of it. Not just that, we have a high DHEA and low, that is SHBG, as we call the hormone binding globulins, and that is why, because the androgen is secreted more and it stays in not as a combined as with the SHBG, but it is freely available to act, and that is why girls turn around to have male type of features.
Correct. So what about, you said male-like hormones are in excess. What about insulin levels? Because insulin is also a hormone. How does this influence the ovary or polycystic ovary syndrome, or how does insulin affect this?
Insulin resistance is considered right now from various theories as the base and the root cause of PCOS. So when it all starts, there is with insulin resistance. The theory has been around for the past 30-40 years, and that has held well so far. I'm sure there are other theories coming up, but this has held so far. And insulin resistance seems to be at the center of the causative factor of polycystic ovarian syndrome. So there is a lot of these people. As such, PCOS is an autosomal dominant disease. So when we have the gene and then it interacts with the environment, such as sudden weight gain or something, these genes gets clicked on and then it goes ahead. What happens is there are certain mutations that happen, which means there is lots of insulin that is secreted in the body, but the secreted insulin is not used in the peripheral receptors, such as the liver, the skeletal tissue, and these parts it is not used. So it accumulates in the body. Insulin is an anabolic steroid, so we start gaining weight, we start having those kind of features as well. So it not only affects on the skeletal muscles, which are all the insulin receptors. So it also affects the ovary and the pituitary also. So this is the reason that polycystic ovarian, this is another reason that polycystic ovarian women start gaining weight, and as they gain weight, it adds more of insulin resistance and it becomes a vicious cycle.
Correct.
And so they have to break it at some point, which is where lifestyle plays a major role.
So, do everybody with the PCOS have irregular cycles?
As I told you, as per our criteria, there are actually 3 diagnostic criteria in the world for PCOS.
Correct.
One is the NIH criteria, the other is the Rotterdam, third is the Androgen Excess Society criteria. Apart from Rotterdam, the other 2 has got exceptions, that some do not see menstrual irregularities,
Correct.
some do not see the polycystic morphology in the scan, whereas in the ESHRE Rotterdam criteria, all 3 factors are taken into account.
Okay.
So there are 3 to 4 types of phenotype, that is the expression or the types of PCOS we see. One, they may not have menstrual irregularities, but still if we see polycystic kind of ovary in the ultrasound with hyperandrogenism and the corresponding hormonal imbalance, we still call them as PCOS. So there are types of it. So some may not have irregular abnormalities, some may not have hyperandrogenism, some may not have this polycystic ovary morphology in the scan, but when 2 out of the 3 corresponds, then we still diagnose them as PCOS. PCOS as such, we call it as a diagnosis of exclusion.
Okay.
So when we are not able to find any other hormonal imbalance as endocrinological pathology, and we see a woman having these kind of problems, we diagnose them as a polycystic ovarian syndrome.
Some people call it polycystic ovarian disease, PCOD. So what is the difference? Is there any difference between PCOD and PCOS, or it's just that now it's only PCOS?
PCOS is the syndrome. PCOD, when it's like, it is not a scientific demarcation, but when there is a milder version, when you see only the ovarian changes in the ovary, then with no other, or let us call it a very mild form, whereas your hyperandrogenemia hasn't set in. That is, you're not having too much of hair, excess hair, or you've not put on a lot of weight, and you're not having excessive menstrual irregularities, then we might call it PCOD. But the scientific term is to call it a PCOS.
So basically now, almost 2/3 of our younger people with acne have some form of PCOS, some form of hyperandrogenism and things like that. So when is it that do they have to come to a gynecologist? When is it that they have to seek a gynecologist's opinion?
Basically, a girl should menstruate at least 8 times a year. If it is less than that, then they should take help from the gynecologist to regularize their cycles. When you do not treat PCOS at the early age, that is at the teenage or at the younger 20s, it builds up. The hormone keeps building up. And so what happens is, when they are trying for a conception, or when they get married, they try for a baby, it becomes all the more difficult. So that is why we now have PCOS awareness in colleges and schools, so that when they start the problem, we start treating them. That way because the moment we have a problem in the ovary, it affects the egg production. So basically, to explain a little bit about why we have that PCOS kind of a pattern in the scan, the basic problem here is there is small follicles we see, that is the cyst as they call it in the parlance, but it's not actually a cyst. These are all small follicles, that is immature follicles. We see many. So the problem is the follicles form but they don't mature and the egg is not released because the LH is very high. We have other male types of hormones, so it does not happen. So these small follicles keep accumulating in the ovary, and that is why in a PCOS ovary, even by the Rotterdam criteria, you should have at least 12 small follicles each in each of the ovary, and the ovarian size should be more than 10 cc for us to even call it a morphologically PCOS ovary. In that case, because these small follicles don't come out and rupture, they start accumulating in the ovary, either in the center or at the periphery of the ovary. So that type of thing happens. So they're not producing a follicle every month means they're not ovulating, they're not producing an egg every month. That is why they have these irregular menses. So it starts building up, the problem becomes more when you suddenly land up. So our aim is to start advising them early so that they can, when they start the process of family, it's a cruise.
So I think that was very clearly explained on what actually happens in the ovary.
It was so nice to talk to you during this PCOS week, because as you as a dermatologist and we in the fertility specialist, we have this common thing as a PCOS where the symptoms overlap and where both of us help our patients. Like we look at the hormonal imbalance and fertility side and menstrual irregularities and how to reduce insulin and stuff like that. But there are other things such as they always have the problem of having excessive hair growth, acne, and coarse skin and oily skin, those things. And I'm sure you are the person who can help our patients. So True. Can you tell us how all you can help our patients?
True. So when it comes to acne, there are very good creams, there are very good medications, oral medications, and we also have certain procedures if they're resistant. Sometimes we have to divide them. They might be wanting to conceive and we don't want to give them certain medications. Or if they're not, if they're just young girls, then we can go ahead with the full treatment. Sometimes we need to do certain procedures. Sometimes they develop marks because of acne, so we can do either peels or lasers for those marks and scars. And for hair growth, that's more disturbing than acne for most of these girls. So hair growth, the only treatment and only solution that can be offered to them is laser hair reduction, because even repeated tweezing or repeated threading, it causes something called as frictional pigmentation, where there's thickening of skin and pigmentation. So if it's such thick hair which they have to keep doing it, the frequency will be once in 3 days, like that. So then it becomes very cosmetically disturbing for them. So that time laser hair reduction is a wonderful solution, but they have to do multiple sessions. They have to be aware that they have to come at regular intervals, do that, and definitely we can give them a good cosmetic improvement of the hirsutism. And the other thing that they commonly have is also pattern alopecia or hair fall. So again, we have a lot of lotions, treatments which they have to keep taking, which they have to keep using, because as long as this pattern alopecia is something where their hair goes into the resting phase. So whatever treatments, either lotions or tablets or even procedures like platelet-rich plasma, whatever we do, we are aiming to keep the hairs in the growth phase, the anagen phase for a long time. So they have to keep using the lotion. Whatever we do, their compliance is very important. So yes, we do have a lot of solutions for them to have a better appearance, especially with the hair and the acne and facial hair. So,
and when we have this hyperandrogenism and especially in hyperinsulinemia, they have these nigricans.
Acanthosis
nigricans, where they have these darkening around the skin and the neck and everything. That is a very major. Sometimes some girls, when they feel very uncomfortable about it. Can you help them as well?
So see, there are different grades with acanthosis also, which reflects on their insulin levels. So the first treatment would be definitely to bring down the insulin levels, lose weight, because by doing that 80% of the pigmentation goes away. So there's no point in us actually applying creams, because these areas, folds, neck, underarms, thigh folds, these are all very sensitive areas, and using strong creams can actually cause a lot of irritation, because I've seen a lot of patients using all that. So if they just lose weight and get their insulin levels down, the pigmentation reduces by 80 to 90%, and after that we have such creams which can help lighten the skin further.
That's great. That's great information that, that actually is very reassuring to know that you reduce weight, even the acanthosis nigricans goes off pretty well, because that dark discoloration is disturbing to some as well.
True. So when it comes to treatment, will just lifestyle changes be good enough? Do they have to take hormonal? When do they have to take hormonal supplements? And when do they just lifestyle changes? When do they have to follow it?
Lifestyle change is the primary and the first line management in any PCOS. So the first thing that we write would be lifestyle change, which is daily exercise. Because as I just told you, the peripheral receptors aren't functioning well, which means there are a lot of insulin in the body, but the peripheral receptors are not using them or unable to use them. To enable them to use it, they have to start working, which means the skeletal muscle has to start working. That is when the excess insulin in the body will be used. So exercise every day for at least 1 hour. I mean, it does not have to be a gym or an aerobics or something. 1 hour of normal walking at least is a must when somebody goes in for a lifestyle change. That is primary. Like, not just weight reduction. You can reduce weight by just diet. Correct. But that's not the only way that you can treat PCOS. If you need to reduce hyperinsulinemia, we need to use the skeletal muscles so that the hyperinsulinemia will come down. So everyday exercise is very important, and you need to diet. Correct. Reduction of weight is important. It has been shown from as early as 1997-98 when Dr. Robert Norman published his results saying that if you reduce weight by at least 10 to 15% of your weight, we don't have to bring it to 60 kgs or 50 kgs. Correct. Just reduce 15% of your weight, then the possibility of ovulation was so much more higher. It increased by about 50 to 60%. So weight reduction is important, but it should not happen just by dieting. Exercise plays a very major role in terms of lifestyle change as a treatment for PCOS. That is number one. Whereas in treatment of PCOS is different when it comes to women who want fertility and women who don't want fertility. In women with fertility, we don't want to put them on oral contraceptive because that's not the aim here. So we start giving them tablets every month such that the ovary starts working. So every month we put them on medical ovulagens such as letrozole, which is a first line choice in PCOS, or if it doesn't work, with the clomiphene citrate, so that the ovulation happens every month, and that way they get pregnant. So that is number one. If they don't want pregnancy, they are not looking like the young girls or young
for irregular cycles.
Irregular cycles. Lifestyle change is always priority. The next thing is we can put them on contraceptive pills. There are very low dose contraceptive pills nowadays, which we can put them on, and after some time we can taper it down, and once the lifestyle has kicked in, they usually have very good outcomes with that. Having said that, there are other medications such as insulin sensitizers such as metformins, which we also use to help girls bring down the insulin. Along with metformin does not work without exercise.
Correct.
So we need that metformin and exercise for it to work. So, but metformin can happen. Now we have many other non-hormonal drugs also, like nutraceutical drugs, which also we use, which are not as effective, but they can be used as on a long term. They just sensitize the ovaries to start functioning better. But none of this can actually cure a PCOS, unfortunately, but it can be controlled. Like the analogy being a diabetes. Diabetes may not be cured, but it can be definitely kept under very good control with lifestyle changes. The same way with lifestyle changes, and if needed some hormonal treatment, PCOS can be absolutely kept under control, and they can be like a normal person as well.
Day-to-day.
Yeah, day-to-day activities may not be affected.
So I think you've explained it beautifully, what actually happens in PCOS and how lifestyle changes play such a key role in controlling and managing PCOS. And so I hope you found it useful. Thank you very much.